Pitfalls for the management of acute pancreatitis.
Diagnosis of acute pancreatitis requires meeting at least 2 out of 3 diagnostic criteria. The first is an elevation of either amylase or lipase levels exceeding 3 times the upper limit of normal. The second is characteristic abdominal pain, typically severe and epigastric in nature. The third is confirmation through imaging such as computed tomography or magnetic resonance imaging. Isolated mild elevations in pancreatic enzymes are not sufficient for diagnosis and can lead to misclassification. Causes of pancreatitis. Not all non-gallstone-related pancreatitis is caused by alcohol use. Significant and long-standing alcohol consumption is usually necessary for alcohol-induced pancreatitis. Other causes, such as genetic factors, hypertriglyceridemia, or malignancy, should also be considered. Mislabeling patients without evidence can contribute to stigma. Prognostic assessment. Overly complicated scoring systems to predict prognosis are unnecessary. Instead, rely on simple laboratory tests such as hematocrit, blood urea nitrogen, and creatinine. The presence of systemic inflammatory response syndrome and close clinical monitoring are also reliable indicators of severity. Fluid management. Excessive fluid resuscitation can harm patients. Moderate fluid resuscitation using lactated Ringer's solution is recommended. Always account for the patient's cardiovascular reserve and fluid tolerance. The first 12 to 24 hours are the most critical period for effective fluid management. Nutritional support. Total parenteral nutrition should be avoided unless absolutely necessary. Enteral nutrition is safer and just as effective. For patients capable of oral intake, starting a low-fat solid diet early is beneficial. Role of procedures. Emergency endoscopic retrograde cholangiopancreatography, or ERCP, is not indicated in biliary pancreatitis unless cholangitis is present. Performing ERCP inappropriately does not improve outcomes in biliary pancreatitis. Antibiotic use. Prophylactic antibiotics are ineffective at preventing infected pancreatic necrosis and increase the risk of multi-drug-resistant infections. Their routine use is not recommended. Management of infected necrosis. Early surgical intervention in infected pancreatic necrosis is not advisable. It is better to wait for the necrosis to become walled off and demarcated, which typically occurs after about 4 weeks. If intervention is necessary due to sepsis, minimally invasive approaches, such as percutaneous drainage, are preferred. Endoscopic techniques are optimal where available. Cholecystectomy in biliary pancreatitis. Patients with biliary pancreatitis should undergo gallbladder removal during the same hospital admission. Delayed cholecystectomy increases the risk of recurrent pancreatitis. Exceptions may apply in cases with extensive pancreatic necrosis or significant comorbidities. Long-term implications. After recovery from acute pancreatitis, patients may develop complications such as diabetes, exocrine pancreatic insufficiency, or reduced quality of life. Long-term follow-up is essential to manage these potential outcomes.
Thank you for watching. Please subscribe to our channel by clicking the subscription button. If you have any questions, feel free to leave a comment below in the comments section.